My name's Gavin Jennings and I'm a specialist shoulder surgeon. This talk will provide an overview of the clinically relevant anatomy of the shoulder girdle. There are three parts covering the normal anatomy, pathoanatomy, and some of the surgical approaches of the shoulder. Part 1. Normal anatomy. Focusing initially on the glenohumeral joint, first a few facts and figures. The humeral head has a surface area about 4 times greater than that of the glenoid on which it sits. The glenoid tilts back about 7 degrees and tilts upwards about 5 degrees. The humeral neck forms an angle of 135 degrees with the shaft, and the head is retroverted about 20 to 40 degrees. The majority of pain arising from the glenohumeral joint and subacromial space is perceived through the suprascapular nerve. The glenohumeral joint is very mobile, but inherently fairly unstable. The shapes of the bones confer very little stability to the glenohumeral joint, but a number of other factors, both static and dynamic, have a contribution. Static factors include negative joint pressure, cohesion and adhesion, the labrum, which doubles the depth of the socket, and the capsular thickenings or ligaments. Dynamic stability is provided by the rotator cuff, the deltoid and periscapular muscles, and to a small degree the long head of biceps. Capsular ligaments include the coracohumeral ligament and the glenohumeral ligaments, with the inferior ligaments being most important to both anterior and posterior stability. The acromioclavicular joint is a plain synovial joint which often has a meniscus and is stabilized by the acromioclavicular ligaments, particularly the superior, and the strong coracoclavicular ligaments consisting of the trapezoid and conoid components. The sternoclavicular joint is an articulation between the clavicle and the manubrium sterni, as well as the first rib. Stability is provided by the joint capsule, as well as the anterior and posterior sternoclavicular ligaments, the interclavicular ligaments, and also the costoclavicular ligaments, which attach to the first rib. There are a number of muscles around the shoulder girdle, but some of the most clinically important include those of the rotator cuff and also the biceps. The rotator cuff consists of the supra and infraspinatus, teres minor, and subscapularis. Supraspinatus arises from above the spine of the scapula and inserts on the uppermost part of the greater tuberosity and is supplied by the suprascapular nerve. Its action is to stabilize the humeral head and assist with abduction. Infraspinatus arises from below the spine of the scapula, inserts on the middle part of the greater tuberosity, and is supplied by the suprascapular nerve. Its action is to stabilize and externally rotate the humeral head. Teres Minor arises from the middle third of the lateral border of the scapula and inserts on the lower part of the greater tuberosity. It is supplied by the axillary nerve, and it stabilizes the humeral head and acts as an external rotator, particularly of the abducted arm. Subscapularis arises from the undersurface or front of the scapula, then passes in front of the shoulder joint to insert on the lesser tuberosity. It is supplied by the upper and lower subscapular nerves and internally rotates and stabilizes the shoulder. The biceps muscle has 2 proximal attachments. The long head passes between the greater and lesser tuberosities in the intertubercular groove and then attaches within the glenohumeral joint to the superior labrum. The short head attaches to the coracoid. The biceps muscle is supplied by the musculocutaneous nerve. Thank you for listening to part 1 of Clinical Anatomy of the Shoulder. Part 2 will focus on the pathoanatomy. Please don't hesitate to contact me if you'd like any further information.